Good afternoon, everyone. Thank you for attending today's webinar on using county-level health data from NCHS to monitor health trends in your communities. I'm Steve Pearson, Chair of the Friends of the National Center for Health Statistics and Director of Science Policy for the American Statistical Association. I have the honor of welcoming you, the first to welcome you and introduce today's moderator. First, let me introduce the Friends of NCHS. We are a coalition of 180 organizations and individuals that support the National Center for Health Statistics. Members of this diverse group are NCHS stakeholders that rely on the data collected, analyzed, and published by NCHS to inform health and healthcare policy and conduct research. Our members include such organizations as the American Heart Association, the March of Dimes, the American College of Obstetricians and Gynecologists, Academy Health, the Population Association of America, COPAFS, and NAFSIS, and we're pleased to have the Executive Director of NAFSIS as our first panelist. Let me now introduce Dr. Bonnie Ghosh-Dastidar, the 2024 President of the American Statistical Association. The ASA is the oldest professional association in the United States, dating back to 1839, and has 15,000 statisticians and data scientists working across academia, government, and industry, all with a fervent passion for evidence-based policymaking and data-driven decision-making. Let me now introduce Bonnie. In her day job, Bonnie leads the statistics department at the RAND Corporation, working in the policy areas of health and social and economic well-being. Her work has included evaluations of neighborhood-level interventions, randomized trials to evaluate the effect of interventions to improve depression and adherence to medications among HIV patients, and general topics in population health. Her statistical areas of expertise include study design, sampling, survey methods, evaluations, missing data, and longitudinal and multi-level modeling. Bonnie, thank you for agreeing to moderate today, and I turn the mic over to you.
Thank you, Steve, and Friends of NCHS. It's a pleasure to be with you today. Thank you to all of the attendees who are on the line today. I want to share just for a second why I'm so passionate about the work that's going to be discussed today. You probably didn't know this, Steve, but my early work in my dissertation was inspired by the NHANES collected also by the NCHS when I wanted to be motivated by real-world problems, and I was deriving statistical algorithms to semi-automatically edit and impute errors and missing values, all a part of routine data collection. To this day, I continue to be a huge fan of the quality products produced by the NCHS and staff and researchers, particularly for the valuable insights that they produce and provide to all of us researchers and practitioners on the quality of health in the U.S. I'm pleased to now introduce our three panelists. Welcome. Dr. Shay Sutton is the Executive Director of NAFSIS, which is comprised of vital records professionals from the 57 jurisdictions across the U.S. and its territories. After earning a PhD in biostatistics, she started as a data quality statistician that led to 17 years of state-level experience with vital records in many roles. She joined the staff of NAFSIS in 2017 and became executive director earlier this year. Congratulations and welcome, Shay. Dr. Bob Anderson is chief of the Statistical Analysis and Surveillance Branch in NCHS's Division of Vital Statistics, where he directs the production and publication of statistics and surveillance data on births, deaths, and fetal deaths. His main expertise is in demographic methodology and mortality statistics. His work has focused primarily on changes in the international classification of diseases and how that affects cause of death statistics, changes in the reporting of sudden unexpected infant deaths, and the quality of cause of death certification. Welcome and thanks, Bob. Finally, our third panelist is Dr. Paul Sutton, the director of NCHS's Division of Vital Statistics. In his career, he pioneered the use of provisional national vital statistics systems, data for near real-time public health surveillance, and led the modernization of the NVSS with implementation of standard-based data interoperability to improve the quality and timeliness of NVSS data. That was a mouthful. Q&A will follow the presentations. Please post questions using the Zoom Q&A. We will be following and moderating after the panelists have concluded. We are recording today's presentations up until the Q&A, and we'll post the recording to the Friends of NCHS website. Shay, the floor is yours.
Thank you, Bonnie. Let me pull my slides up. All right. So hello, everyone. My name is Shay Sutton, Executive Director of NAFSIS, and I'm delighted to welcome you to today's briefing, excuse me, and share some background on the importance of vital records, as well as the role of states and of NAFSIS in collecting and stewarding vital statistics, before we then hear in more detail how you can use these data and the tools that NCHS provides. Vital records might seem like just another set of documents, but they are, in fact, the backbone of our personal and public history. They tell the story of our lives from birth to death and everything in between. Today, we'll uncover the critical role these records play, not only in our individual lives, but also in uncovering public health trends and shaping public health policies and research. We'll explore how these records are meticulously collected and maintained, and why their accuracy and reliability are paramount. We'll also delve into the history of vital records, tracing their evolution from simple legal documents to essential tools for public health. By the end of this presentation, I hope you'll have a deeper appreciation for the significance of vital records and the meticulous work that goes into maintaining them, as well as be able to use the resources from NCHS to apply these data to your work. Thank you for being here, and let's get started. So NAFSIS is a national nonprofit organization representing the state vital records and public health statistics offices in the United States. We ensure the secure exchange of vital records data across the country. This is essential as people often move between states, and having a centralized data exchange platform helps maintain accurate and up-to-date records. Additionally, we provide national advocacy, technical assistance, and training to our members. These members represent 57 jurisdictions, including all 50 states, New York City, the District of Columbia, and 5 U.S. territories. Moreover, NAFSIS operates national electronic systems that facilitate the movement of vital records data. This not only helps in preventing fraud, but also supports public health by providing critical data for tracking health trends and addressing health disparities. In addition to serving state governments, NAFSIS plays a critical role in supporting federal agencies. Many federal programs and policies rely on accurate and timely vital records data to function effectively, such as the Centers for Disease Control and Prevention, which uses data to monitor public health trends. NAFSIS plays an important role in ensuring that our vital records are secure, accurate, and accessible, supporting both administrative needs and public health initiatives at both the state and federal levels. So what are vital records? Vital records are the official records of our lives. They capture all the important details. Vital records represent people. They are the permanent legal records of life events, such as births, deaths, and fetal deaths, marriages, and divorces. Before you can get your driver's license, your first passport, or even enroll in school, you need a birth certificate. It all starts with vital records. So now let's talk about the state's role in collecting vital records. You might think this is a federal job, but it's managed by each state, not federal statutes and regulations. That said, many federal agencies rely on state vital records offices to carry out their own work. The 57 vital records jurisdictions in the U.S., as I stated earlier, the 50 states, New York City, D.C., and 5 major territories. When it comes to reporting vital events like births and deaths, it's all about where the event happened, not where the person lives. So if you're born or pass away while traveling, that state collects and maintains the record. Every birth and death record must be reported to the State Registrar of Vital Records. Fetal deaths are also reported, with requirements varying by state based on gestation or birth weight. Some states also keep centralized records for marriages and divorces. So the next time you come across a vital record, remember, it's not just paperwork, it's a piece of your state's history. So a fun fact, the practice of recording vital events in the U.S. goes all the way back to colonial times. Initially, these records were just legal documents to protect property rights. But as time went on, their importance for public health became clear. In the 18th and 19th centuries, epidemics like cholera, yellow fever, and typhoid were wreaking havoc. These health crises highlighted the need for reliable data, and by 1833, cities like Boston, New York, Philadelphia, Baltimore, and New Orleans started requiring the reporting of births and deaths. As public health and preventive medicine evolved in the late 1800s, vital statistics became essential for tracking and controlling diseases. Now, fast forward to the early 1900s, and we see the creation of the first model law for vital registration. NAVSIS was first established as an association in 1933 to support vital records functions and help develop standards. By 1935, all states had standardized the reporting of births and deaths. Then the 1930s brought Social Security and private pension systems, making birth certificates crucial for proving age, and during World War II for proving citizenship. In the latter half of the 20th century and continuing today, the need for vital records has only grown. As health and social issues become more complex, the information we collect has expanded significantly. Tracking vital records helps us understand public health trends, inform policy decisions, and allocate resources effectively. First, vital records helps track health trends over time. For instance, birth certificates can provide data on birth rates, maternal health, and infant mortality rates. This information is crucial for identifying public health issues and developing targeted interventions. Secondly, they help with disease monitoring. Death certificates include information about the cause of death, which is vital for monitoring disease outbreaks and understanding mortality patterns. This data can help public health officials respond to epidemics and pandemics more effectively. The more timely and accurate our death records are, the better understanding we can gain of an ongoing public health crisis or emergency. For example, during the early stages of the COVID-19 pandemic, accurate death records were essential in tracking the spread of the virus and understanding its impact on different populations. This information helped shape public health responses and allocate resources to the hardest hit areas. Third, accurate vital records enable governments and health organizations to allocate resources where they are most needed. For example, if a particular area has a high infant mortality rate, more healthcare resources can be directed to maternal and child health services in that region. And lastly, vital records are essential for policy development. Policymakers rely on data from vital records to create and evaluate public health policies. For example, if data shows an increase in deaths due to a specific disease, policies can be implemented to address the underlying causes. Plus, vital records definitely have a fascinating history that shows just how vital they are to our society. So who uses vital records? Everyone does. Not only individuals, but the 57 vital records jurisdictions work cooperatively with federal agencies to share vital records for specific uses. The data collected on vital records are the source for national vital statistics reported by CDC's National Center for Health Statistics and for the National Death Index. Federal agencies that use vital records for administrative purposes include Social Security Administration's Enumeration at Birth program, in which birth information is transmitted securely by each state's Vital Records Office to SSA to issue Social Security numbers for most babies that are born in the United States. State reports of death are also submitted electronically by vital records to SSA, often within 6 days of death, for use in benefit administration. Every country in the world has some kind of vital record registration system because people and governments across the board need validated identity records. So why should we care about vital records? In 2016, Florida experienced the first locally transmitted case of the Zika virus in the continental United States. This outbreak was particularly significant in Miami-Dade County, where the virus was spread by local mosquitoes. Vital records, especially birth certificates, were crucial in monitoring the incidence of microcephaly and other birth defects linked to Zika. This data helped public health officials identify and respond to the outbreak more effectively. Death certificates and medical records provided essential information about the spread of Zika virus. This data was used to track the virus's transmission patterns and implement control measures such as mosquito control programs. The data collected from vital records informed public health interventions, including education campaigns about preventing mosquito bites and advising pregnant women to avoid travel to affected areas. The Zika virus outbreak in Florida definitely illustrated how vital records play a critical role in public health by providing the data needed to track diseases, understand their impact, and implement effectiveness. So I hope this has helped you to better understand the value and importance of vital records. Thank you so much for attending today. My information is on the screen if you wish to reach out to and contact NAPSIS. And now I'll turn it over to Dr. Bob Anderson with NCHS.
Thanks, Shay. That was a nice overview of the National Vital Statistics System. So my job today is to sort of show you how you can get your hands on some of these data. I just wanted to say at the outset that, I mean, the data can be accessed in several ways. We have standard reports and web releases. We do release some microdata. And we have a tool, it's called CDC Wonder, that allows for a fairly easy access. I think it's probably the most accessible and flexible tool that we have for providing data. And so what I'm gonna do is I'm gonna provide you with a live demonstration of how to access some of these data. I'm gonna provide a few examples. It's not a comprehensive view of CDC Wonder. We don't really have time for that. There's a lot of information in there. The purpose is really to show you what Wonder can do and some of the things that are in there, and to some extent, what it can't do as well. It's not particularly complicated once you get used to it, but even for those who understand the subject matter, it does require some practice. There's a fairly steep learning curve with regard to CDC Wonder. So I do want to mention that if you decide you want to get data this way and you want to use this tool and you have questions, you should feel free to contact NCHS, and we can certainly help you to sort of navigate the system and learn how to use it. So let me share my screen here. Make sure that I'm sharing the right one. I think that's correct. Okay. Can somebody tell me if I'm showing the CDC Wonder screen?
Yes, you are. We can see it. Thank you, Bob.
Excellent. Okay, great. Okay, so this is the opening screen for CDC Wonder. It's found at wonder.cdc.gov. For some reason, there's no www there. I'm not quite sure why, but that gets you to CDC Wonder. I'm sure you can find it in a search engine as well. So there are a lot of databases that are accessible via CDC Wonder, much more than just the Vital Statistics databases. But of course, I'm going to just talk about the Vital Statistics databases here. Let's see. So you've got birth data here. We've got a bunch of death data. And I'll talk about each of these separately. But let's start with the birth data, since births come before deaths. We usually like to talk about births first. So we click on births here. You can see that there are a few databases for births that show up. There's a provisional database, and then there's some databases for final. Now these are separated out mainly. There's a description down here as to exactly why, but basically it's because there have been some changes in some of the data that aren't exactly comparable year to year, and so you have to be careful in making comparisons, particularly with regard to race. And I mean, there's some other issues as well, but these are separated out for that reason, to make it easier for you to understand where those changes occur. Let's see. So let's select the natality for 2016 to 2022. That gets us to the most recent final data. Now, whenever you go into one of these databases, you're going to get this screen here, this opening screen, and this is basically just a data use restrictions. It basically says that you'll use these data for health statistical purposes, reporting and analysis only, that you won't, that you'll abide by the suppression rules, and that you'll make no attempt to learn the identity of any person or facility, and that if for some reason you do find something that is identifiable, that you'll notify us as soon as possible if that happens. We think we've got a pretty good handle on this, but if you do find something that could be used to identify a particular person, then we want to know about it so that we can fix that. So basically you click agree to these terms, and then that brings you into the query page. Okay, so I'm just going to run through a couple of queries, but before I do that, let me just show you how this query form is laid out. I mean, there's a whole bunch of sections here. You've got table layout section with a lot of different indicators. You've got maternal residence, and in here you can actually drill down to the county level as well. So here you got state and county level information. Here you've got maternal characteristics, paternal characteristics, some paternal characteristics, pregnancy history and prenatal characteristics. So there's a lot of information here. Maternal risk factors, pregnancy risk factors, maternal infections, and then you got delivery characteristics. So lots and lots and lots of data. So I can't cover all of this in the time we have. So what I'm going to do is I'm just going to run through. Let's just do really quick. Let's do the national trend for births, and we'll group results here by we want to do this by year. So I have to scroll down here and find year, and we'll do the birth rate and the fertility rate. And then we have to scroll down to all the way to section 10. So this defaults with the most recent year, but since we're doing a trend, we want to select all years. And then we'll click send, and you can see there's a send button sort of all over the place. So you don't have to scroll all the way up or all the way down to do that. You just click send wherever it's located. And this is going to give us the trend in the birth rate, just the national trend in the birth rate and the fertility rate from 2016 to 2022. You can see that shows the number of births, total population, the birth rate, the female population, and the fertility rate. Now, the difference between the birth rate and the fertility rate, the birth rate is based on total population, and the fertility rate is based on females aged 15 to 44. So that's really the only difference there. But two important measures, different but important measures. So now there are some data visualization functions in CDC Wonder. You can see if you click on the chart, you can see that there is a chart here, and you can make some changes to this. Let's say we want the fertility rate, we can click on that. We can do a line chart. Here we have to make it vertical rather than horizontal, and then you can see it's not the greatest visualization, but it can give you an idea of what's going on, at least. My understanding is that the CDC Wonder platform is being changed, and that they will be upgrading the visualization capability at some point. So all right, so let's go back. Oh, one thing I do want to mention here is that if you're going from results and you want to go back to the query form, rather than hitting the back button, it's best just to use the tabs so that you don't lose what you've been using. All right, so let's do one here also. Let's do one by county. Let's see, where's that should be up here. Here we go. County of residence. And then let's see, do we want, let's select the fertility rate and take a look at the fertility rate. And we'll do this for Alabama, let's say. Okay, and then we'll send. So here we've got county level data for Alabama. Now, one thing about the birth data is there are some confidentiality restrictions in terms of what information that you can get. What are shown here are not all of the counties in Alabama. I mean, if you're from Alabama, you'll know this. This is only counties of 100,000 population or greater. And so all the rest get lumped into this unidentified counties category. And this is just for confidentiality protection. All right, so here we've got births, we've got the female population, we've got fertility rate. You can order these by using these arrows. You can order from highest to lowest, or you can do it the opposite way around, however you like. So there's some nice things about this. There also is a mapping function that will allow you to map out these. Obviously, we're missing a lot of counties because of the lower populations there. But at least you can see what's going on with the counties that have 100,000 population or more. All right, so let's go back to the request form. One other thing that I wanted to mention here is, the suppression criteria are such that anytime you have a cell that's less than 10, that's going to be suppressed. So let's do this again, and let's select the American Indian or Alaska Native mothers. And then you can kind of see how that plays out here. So here we have the county level data for the American Indian mothers and the fertility rate. Okay. And I think, let's see, there no 0 rows. Well, this isn't exactly what I'd hoped for. Hold on, let's see, what did I do? County. Let's try, maybe I did Asian. Let's try Asian. Let's see, because I want to get to a place where I can show you the suppressed data, but it doesn't look like I'm doing a very good job of that. Let's see, let's do the Native Hawaiian. There won't be very many of those folks. And here we Okay, so there are some suppressed data in here. So to show the suppressed data, it doesn't show the data, but it shows where it's suppressed. You can use these quick options here, and you can see here that Houston County, Alabama, the data are
Bob,
suppressed. Yes.
sorry to interrupt you, but there was a request to see if you could maximize the screens. It might make it easier for people to see titles.
To maximize the screen? Oh, you mean to make it bigger? I'm not sure I know how to do that. Hold on, let's see. Is that
Currently,
better?
your browser is not filling your desktop, so I wonder if you just maximize the browser. Yes, try that.
How's that? Is that better?
It is better.
Let me
Questioner,
see if I
let us
can
know
make
if
it a little
that's
bit
sufficient.
bigger. How's that? That made it a little bit bigger. Is that better?
I think so.
I think that's
We'll
about
we'll
as
let
good.
you know if the questioner what
Okay.
the response
Yes,
is.
I do think it's better. Yeah.
Okay.
Mhm.
All right. Good. Okay. All right. So anyway, so there you can see the suppressed data. We do show zeros as well. Those are just typically any a place or cell that's suppressed or 0 is initially hidden, but you can show that by using this quick options thing. You can show the 0 rows or show, I don't think there are any 0 rows in this case, or you can show the suppressed ones, which ones are suppressed at any rate. So, but those data, unfortunately, because for confidentiality reasons, just aren't available. So let's go ahead and move to, just in the interest of time, let's move to some death information. So the data here coming from death certificates. So let's do, let's go to, well, there are a whole bunch of death databases here. There's underlying cause of death. The underlying cause is just the condition that initiated the chain of events leading to death. And it is what we typically use for statistical presentation. Multiple causes of death includes all conditions reported on the death certificate. We have provisional data and final data there. There's some data from the US-Mexico border area, and this is from the US-Mexico Border Commission. Well, they prompted us to do this. Then there's this compressed mortality file. The compressed mortality file actually has data going back to 1968. So there's a lot of information there. It's a little bit less detailed than the other, but still quite useful. And then of course we have fetal death data and infant death data. And the infant death data actually comes from the linked birth infant death records. And so it basically has information from the birth certificate and from the death certificate. So it's quite a lot of information regarding infant deaths. Okay, let's see, let's do here quickly just a couple of queries. So we'll go to the multiple cause of death, and I'm just going to do the provisional multiple cause of death because that has the most recent data. And there's our data use restrictions page, confidentiality page. And so here I'll just run through what we have for deaths. Here again, we have the table layout section, section that shows the residence of the decedent, and also where the decedent died, because it's not always the same. We have information on urbanization here, basic demographic information, time period. Now here you can drill down to month. You can also drill down to week. We've got some information on whether an autopsy was performed and where the death occurred. Then we have the underlying cause, and we have multiple cause information. That's pretty much what we have. So there's a bunch of different ways to get to the cause of death. We have our standard cause list. If you can use these radio buttons here, you've got our standard cause list, which has data already grouped. We also have one for infants. We have an injury, intent, and mechanism. So if you wanted, say, firearm suicides, you could click on suicide and firearm. You could do that. And then we have one for drugs as well. And so what I wanted to do here is do a quick query on drug overdose deaths. Just we'll show the national trend here. So we're going to select year. We're going to select the age-adjusted rate because that's whenever you're doing annual data, age-adjusted rate is important. Then we're going to need, let's see, we're going to need to select the drug overdose categories. And here are the drug overdose categories. There are 4 of them, and you can select them by just holding down the control button to select each one, just so that they all appear in this box here, the currently selected box. And then click send, and this is going to give us the trend. Deaths, population, there's the crude rate, which is just the number of deaths divided by the total population, and the age-adjusted rate, which accounts for changes in age distribution. So you can see the 2023 data are still provisional, so that's noted there. So it just flags that for you so that you know that the data aren't complete quite yet. The 2023 data at this point are pretty complete. We have most of the data in, but you can see the 2024 data are very much not complete. And so that is actually flagged as provisional partial because we're not even out of the 2024 data year yet. Now, one thing to note about things like drug overdose, the information provided is provided with a 6-month lag for provisional data because drug overdose information tends to lag coming in to NCHS because a death investigation is required and toxicology can take a long time. All right, let's do one more here. I know that there's a lot of interest in fentanyl deaths. Now we can't show fentanyl specifically, but we can get pretty close. Let's do is sort of a state level query here. We got residence state, and then let's see, we'll want to select, let's just do it for 2023. And then we've already selected the drug overdoses, but now we have to select the category that gets us as close to fentanyl as possible. And that's going to be down here in the ICD codes. So that's going to be the code for other synthetic narcotics, which is where fentanyl falls, is code is T40.4. That's the ICD code for this. It's right here. This is about 95% fentanyl. So it's a pretty good proxy. It's not exact. There are some other drugs in there, but it's about 95% fentanyl. So it works pretty well. Unfortunately, the ICD is not detailed enough. So we move that over here. So this is going to get us drug overdoses where there's a mention of other synthetic narcotics, such as fentanyl.
Well, there are two
yes.
questions for you. Maybe I'll just read them aloud. One is, how do you get detailed data, example by age, for a specific county? And there's a related question. Is any of the data available by demographics, for instance, African American versus Hispanic, etc.?
It absolutely is, and I'll show you where to get that here in just a moment. So this is the data for the other synthetic narcotics, and you can see we do have a map function, so we can actually create a map showing those data as well. All right, so to answer the questions, let's go back to the query form here. You can see here in section 3, we do have demographics. So you can see the race categories, Hispanic origin, gender and age, and you can actually do this in, these are our standard 10-year age groups. We've got 5-year age groups you can select, and you can actually select single years of age as well. And then if you're interested in infants, you can go and do some stuff with infants as well. So it's fairly easy to do this. You can also group, so you can either select, if you're interested in a particular age range or you're interested in a particular group, you can select them there in, sorry, let's go back here. You can select them in section 3 here. You would just, select American Indian or Alaska Native, or you can group results by those categories. You can see the age groups here, gender and race as well. So, I mean, there are lots of different options and everything like that. These are things that you'd need to look into. There is information on the site that can guide you. And as I said, you can also reach out to NCHS, and we can sort of walk you through how to get the information that you need. So, I mean, there are other things you can do here. As I said, you can do data by week, which is kind of nice. There is the last thing that I wanted to mention here is sometimes figuring out what ICD codes to use is really difficult. There is a search function here that will allow you, let's say you're interested in cardiomyopathy, which doesn't fall in any of the standard cause lists. You can type in cardiomyopathy. You can see I already did that just to make sure that it worked. And then it will give you any place where cardiomyopathy is mentioned in the ICD. I mean, this I-42 is the main category, but just to be cautious, because sometimes this can be a little complicated. It may show up in a bunch of different places, and you don't want to use all of these codes. Really, you want to make sure that you have the right code. And so I would say, if you're unsure what codes to use, contact us and we'll help you determine what codes to use. Okay. That's pretty much all I have. Bonnie, do we wait for questions, or should I just turn it over to Paul?
So Bob, I think it would be best to stop sharing and turn it over to Paul.
Okay.
And if in the chat you could provide a link to the guide, I can see that your presentations generated a ton of interest. People are trying to figure out how to get to this section page. Can you provide a link to the guide? You could do that in the chat. I just have to say, as Paul shares, I didn't realize, but in my presidential speech, when I said that in 2020 and 2021, firearm injury was the leading cause of death of children in the US, it was everybody kind of paused to listen. Thanks to you, that's really how I got the data. So this has really great causes of death. So if you could just provide the link for the guide, and that might be great in the chat, Bob. And Paul, you're ready to share anytime then.
Sure. Thanks. I actually don't have any slides to share. I have a few fairly brief comments, partly just tying together some of the things that Shay said with what Bob was talking about. I mean, as Shay said, Vital Records has a very long history going back decades and decades and decades. But some of the things that Bob was demonstrating, specifically with mortality data, with the provisional data, where we're talking about things that didn't happen a year or two ago, but things that were happening just a few weeks or a few months ago, is really quite new and really quite novel. And the ability to do that is really raise the profile and the value of vital records even beyond where it was, to where we can really contribute quite a bit to conversations about public health response questions to ongoing emergencies, such as the COVID, such as the drug overdose crisis, et cetera. And when I say that it's quite new, we're really talking these capabilities really didn't exist at all in any form, even 10 years ago. And to have the type of access that Bob just demonstrated, where and somebody outside can get in and actually do these types of tabulations with provisional data, is really only available in the past 2.5 years or so. We first had the provisional mortality data was released right at the very end of 2021. And it was only just about a year ago exactly that we increased the frequency of updating that to a weekly basis, so that we were updating that data on a weekly basis. Also, about a year ago is when we first made the provisional birth data available. All of that was possible because of a lot of efforts that have gone into modernizing the National Vital Statistics system more broadly, that we've been working on for some time. As I said, we have been working on that for a while, but it's very much an ongoing process, and it's been incremental to get to the place where we are now, but it's very much a job that's incomplete. Some successes, though, that we do have to talk about. One is obviously the availability of these provisional data in a much more timely way than it's ever been available. Part of that is the result of efforts that have happened both at the national and very much at the jurisdictional level to improve the timeliness of reporting, to where the data is being collected and reported up to NCHS to be included in these in these databases much more timely. One of the things we've really worked on recently to help accelerate the timeliness even more is a real focus on interoperability of systems. And we've had a lot of progress already in interoperability between the state vital record systems and NCHS systems, where we're already seeing, bidirectional real-time interoperability between those systems in a number of states. Currently, 8 states have that active, but there's a laundry list of states that are actively working on getting that capacity up. A year ago, that number was 0. So again, an area where we're seeing active progress being made. Another area where we've made progress in terms of timeliness is fairly recently, just a few years ago, we implemented a brand new system for coding cause of death that helped us improve both the quality and the timeliness of data by allowing more deaths to be coded automatically and not having to be coded by a manual intervention that could take days as opposed to just a few minutes. All of these things have really helped accelerate our efforts to make these data available. You know, as I said, though, this is still very much an ongoing process. I mean, modernization is not complete. As I mentioned, only 8 jurisdictions currently are in production, sending us data in real time using the new FHIR standards, which I won't necessarily go into the details of that. But more states are working to send this mortality data in this way. We're only at the very beginning of the process for sending birth data, however, and making that more interoperable. And then the real opportunity interoperability is not as much between the jurisdictions and NCHS, but looking at using that same technology and extending it upstream to the individuals and institutions that provide the data to the jurisdictions. So looking at using some of that same technology to implement interoperability between electronic health record systems and the state systems, really just at the very beginning of that process. And there's just enormous opportunity there to improve the quality of the data that's available. And finally, because I want to make sure we have plenty of time for some questions, there's other activities and opportunities within things. So one other area that we have a lot of work going on right now is in the area of collecting more detailed and again, improving the quality of our geographic data. Bob demonstrated some of the geographic data that's already available, but we are in the process of building the capacity to where we will be able to geocode these data that will allow us to make sure that the quality of the data are both improved at these smaller levels of geography, and ultimately will allow us to make more detailed information available as well in at least some of our data platforms, not necessarily in the Wonder platform, but through some visualizations and some of our reports and things we'll be generating. In the coming years, you'll be seeing more detailed geographic information available, allowing us use vital records data to not just talk about what's happening at the nation, or the state, or even the county, but sometimes even down to much smaller urban areas, and not much bigger than neighborhoods in some situations where the data size permits. So there's enormous growth. There's a lot has happened, but I think there's a lot of opportunities still out there, and over the next few years, we hope to be able to make more of that available to you. So in there and turn it back and open it up for questions, or back to the moderator to manage that how they will. Thanks.
Well, thanks for the great talks. I see that there's a lot of interest in actually using this data. I'll just start. I have some of my own questions, but I'll just start with the questions I see in the Q&A. So some of it, there is a link to the guide, so in the chat for everyone that's on the line. How do you get detailed data by age for a specific county? Is it fair to just refer that to the guide, Bob?
Basically, you would group. The best way to do this would be to group the data by age in section 1, and then select the specific county. A county of residence or county of occurrence, depending on which one you're interested in. You would select that, and that would allow you to get age-specific data for that particular county. I recognize that if the county has a relatively small population, a lot of those age groupings may be suppressed if there are not enough deaths. But if it's a large county, you probably could get a good age distribution of the deaths for that county. But that's how you would do it, is you'd group the results by age, and then you would select the specific county that you're interested in.
Thanks. There was a question related to ICD-10 codes not being tied to reimbursement. Bob, thoughtful reply there. please
Yeah,
look?
well, I mean, it's important to know that the folks that report cause of death on death certificates don't report in the form of codes. They report in free text. So we do the coding. NCHS does the coding for all of the states, and about 85% of deaths are coded using an automated coding system. And then the 15% that the automated coding system can't handle are coded by expert mortality coders. So the coding is actually quite accurate. But we do rely on physicians, medical examiners, and coroners, who are the cause of death certifiers, to report accurate information on the death certificate.
That's great. A lot of effort to make sure it's accurate. Is there a timeline for when data will be available by the new Connecticut planning regions?
Yeah, I'm not exactly sure when that will be available. I think we are shooting for the 2023 data release. Paul, do you know any more about that?
That's still currently the plan, is to have for the 2023 final data release.
And hopefully that will be in December. We're currently on track to release the 2023 final data in December. And at that point, CDC Wonder will be updated with those final data. And we should have the Connecticut planning regions incorporated at that time for that release.
It would be really great also to have the email address that people can contact. I think that could be tapped in the chat for if they need help with accessing CDC Wonder. That probably could be.
You should contact CDC Washington, the CDC Washington office. I think you all should have contact information there, and they will connect.
It's on the website, Bob.
Yeah.
One question maybe for Shay. What measures are being taken to modernize death data reporting and improve the accessibility of this information for policymakers, public health affairs officials, and others?
Yeah, so Paul talked about this a little bit already, and the efforts that have been really collaborative between the National Center for Health Statistics, NAFSIS, and the Vital Records offices, and working on modernizing their systems. They've been able to get some funding to those Vital Records offices through the public health data modernization efforts that have helped them to really enhance their systems and modernize them. Some people may think that all Vital Records offices these days have electronic systems, but there are a few that were able to just recently, in the last couple of years, be able to implement those for all of their vital events. And there's still a few of the territories that don't have those in place. And so definitely wanting to move forward and continue to enhance those systems to be able to work collaboratively and send that data. Those efforts really are helping to make that data accessible and be able to integrate new technology so that we can send real-time or near real-time reporting so that it can support those policymakers and provide public health officials with quicker access to the vital records data.
Thanks, Shay. I see a question in the chat, and I don't think this was answered yet. Somebody who had to join late, and that's just fine. There will be a recording available of this webinar. Are age-adjusted rates going to be released for county-level mortality data in the future?
Yeah, that's a good question. The answer is yes. We'd hope to already have that capability. Unfortunately, some of the data at the county level, some of the age-specific detail isn't available for the more recent years. So we are working on a sort of a slightly different method for calculating age-adjusted rates. We'd hope to have that up already, but it will probably be November before we'll have that option. But we will have the option to calculate age-adjusted rates at the county level as soon as we can, but it'll probably be November before we'll be able to have that available.
So while there's a slight lull in the Q&A, I'm going to jump in and tag team with something Shay said. Everybody wants local, actionable, timely data. What are the biggest challenges in terms of publishing the vitals data in a timely manner?
Well, yeah, Shay, did you want to
No, you go
answer
ahead,
that?
Bob. I'll
Okay.
let you start.
Yeah, I mean, the biggest challenge that we have in publishing timely data, of course, is getting the data in a timely fashion. And in most instances, we do get the data in a timely fashion. And so we're able to provide, it's not, obviously it's not real time. We're never going to, I think, be able to provide real time data, but we can provide near real time data for most causes of death. Now, some states are a little slower than other states in getting their data in, and so we might have more timely data for some states than for other states, but generally for the nation, the data are pretty timely. Where we struggle a bit with regard to timeliness is with deaths that require a lengthy death investigation. So here we're talking about drug overdose deaths, suicides to some extent, sudden unexpected infant deaths. These are deaths that require a comprehensive death investigation, toxicology, which in some jurisdictions can take a very long time. And so the lag in terms of timeliness is a lot greater than it is for other causes of death, where the cause of death may be more apparent and more straightforward. So currently in CDC Wonder, we have a 6-month lag for those sorts of deaths. Obviously, we'd like to get faster than that, but at this point, that's about the best we can do.
That's fair, Bob. And that's really helpful to know where it takes a little bit longer versus things that are really timely. Could you provide an update on the status of ICD-11 implementation at NCHS?
Okay, sure. Yeah, so ICD-11 is a thing, and it was released by WHO recently. We do have an implementation work group at NCHS that is working on this. There is a lot that has to go into any revision of the ICD. I'm old enough to have gone through the ICD-9 to ICD-10 transition back in the late 90s. The ICD-10 to ICD-11 transition won't be that different. Our biggest challenge is in reworking our auto coding system for ICD-11, from ICD-10 to ICD-11. So that is something that we're working on. We hope to be able to implement ICD-11 somewhere around 2028, 2029. It could slip further than that if we have sort of technological issues with the auto coding system, but hopefully we'll be able to do it sometime before the end of the decade.
Maybe I'll slip in this real pragmatic question. Can results be downloaded in Excel?
They can be downloaded in, there used to be a CSV option. I hope there, but currently you can't do that. You can download it in text format and then import it into Excel, or you can copy and paste, which is the way I usually do it. I hope that CDC Wonder's new platform, they're currently migrating platforms. I'm hoping that when they do that, they'll be able to provide an export to CSV function. That's something that we would like to see.
Yeah, that makes a lot of sense. There were some thanks for that. What they said is an enormous lift, thanks to NCHS. Maybe one big picture question. I know we're on the hour and you still have a good number of attendees. Besides meeting this burden or request for relevant, timely, accurate data, what are some kind of hopes or directions for innovation to improve efficiencies, meet data user demands, understanding fully many things are cost constrained, right? Like if we had infinite resources, things can happen overnight. But would anybody like to take that question?
I don't know, Paul, you want to say something about that?
I mean, I mentioned a few of the things that we're already working on. I think infinite resources is sort of a big dream, but I mean, obviously right now we're still very much focused on the ongoing work that we have. I mean, I think the opportunities just within the interoperability space are still tremendous. We've barely scratched the surface on what having interoperability with EHRs and some of those upstream data systems are. I think that's really the future of our vital records. I mean, we've made a lot of progress, as I mentioned, between jurisdictions and us, and I think that helped establish a strong foundation for the technology around interoperability, but extending that into other use cases is enormous. I also mentioned, the finer geographic data, which I think we hope to be able to start doing in the foreseeable future. And I think looking for ways to disseminate that in a way that preserves confidentiality while providing as much access to that fine geographic data, because so much happens at the very local level, is important. So ways to maximize our ability to disseminate that data and preserve privacy is critical. That would be another area of real opportunity as well.
Well, thank
If
you
I can-
all. Yes,
If I
Shay.
can add to that really fast, Bonnie, I think also if we had infinite resources, vital records offices at the state level often struggle with their budgets and trying to fill in the gaps in resources and staffing, not only just their systems, but their staff as well. And so I think a need there is really trying to allow them to hire staff with the correct skills, especially with all the new technology that's coming into play with modernization efforts. I think that would be an important thing too, is really take a look at the resources in those state vital records offices and make improvements there too.
And I realize when I say infinite, that sounds kind of crazy. It's really sufficient or adequate, right? Because we know that sometimes statistical agencies could do with a little bit more resource and budget because it's a fast changing environment. Well, I just wanted to take a second to thank you all for all the data that you've been providing me. I didn't even realize I just used your data in August or cited it. And if anybody has some parting words, please go forward. But just thank you for your time today.
Yeah, glad to be here. Thanks, everyone.
It's been a pleasure.
Thank you all.